and welcome to another episode of Famhealth Live. We take pride in bringing you the best doctors and experts regarding all diseases and regarding information and the right knowledge about those diseases. Today on the show, we are privileged to have with us Dr. V. Mohan, who's the Chairman and Chief Diabetologist at Dr. Mohan's Diabetes Specialty Center and the President and Director at Madras Diabetes Research Foundation. He has also been identified as one among 5 scientists from India who are listed by the Stanford University in the top 0.4% among all scientists in the world in the specialty of endocrinology and metabolism. Good evening, Dr. Mohan,
Good
and thank
evening.
you so much for joining us today.
My pleasure.
First and foremost, I hope amidst this entire crisis that's going on, I hope you're doing well. I hope your family and your support staff is doing well.
Thank you. So far, so good. Most of us have been vaccinated, so fingers crossed.
So, Dr. Mohan, to delve directly and very quickly, since you're an expert in the field of diabetology, first and foremost is that what is the drastic link of diabetes with this COVID disease? What exactly is happening in the body that's causing the complications?
So from the first of all, see, diabetes is a condition where your immunity is not great. It is lowered. This happens in many diseases. Diabetes is not the only one. If you have a malignancy and if you are on, say, chemotherapy, your immunity is lowered because what happens is in the process of fighting the cells of the body, the chemotherapy lowers your immunity. Also, your other cells also get damaged. In the case of diabetes, not a direct damage, but all types of immunity, acquired immunity and the innate or the inborn immunity, the cell-mediated immunity, there are different types of immunity. Almost all of them are affected by diabetes. So if you have uncontrolled diabetes, I think that's the byline, or that's the overarching term that we should use. Uncontrolled diabetes leads to a severe decrease in the immunity. And therefore, all infections are more common in diabetes, right from a boil or a furuncle or a stye or urinary infection, TB, to you name it. Most of the infections in the body are much more in diabetic patients and much more severe in diabetic patients. There are many other viral illnesses that are also more. For example, herpes zoster, herpes simplex, many other viral infections are much more common in people with diabetes and more severe. A simple herpes zoster infection of the face or something can take much longer to heal in people with diabetes and can be more infectious in people with diabetes. So from the first reports which came from Wuhan, somewhere in December of 2019 and January of 2020, it became clear when they looked at those who had serious infections requiring admissions, ICU admissions, ventilator support, and deaths. People with diabetes are 3 times more likely to have all of these compared to people without diabetes. You have age matched. If you match the age of a, say, 50-year-old diabetic person, 50-year-old non-diabetic person, the deaths and the outcomes were worse, almost 3 times higher. In fact, the initial fatality rates were 2 to 2.5% in the normal population, in the whole population in Wuhan of all those who got COVID. It was 7.5 in those percent of those who had diabetes. But remember that also these people, when they had COVID-19, mostly they have type 2 diabetes. And type 2 diabetes is a disease of old age, older age. So it's usually above 50, 60, 70 that you get type 2 diabetes. So it's not just diabetes alone, they're also older people. So you've got age and diabetes now. Remember, a lot of them can have heart disease, a lot of them can have hypertension, a lot of them can be on various medications. So number of factors contribute to diabetic people not doing as well. So but I call it as a bi-directional relationship. So if COVID attacks a person with diabetes, then that COVID gets worse because the diabetic milieu or the body of the diabetic patient is weaker, and therefore the virus can take over and do more harm. But also, COVID-19 can produce diabetes. Now, how does, in a person who doesn't have diabetes at all, COVID-19 produce diabetes? In 3 or 4 ways. In the first phase, we had it. Now, it's not so much now in the second phase, although the number of cases are more. When the first phase came, go back 1 year of our life, let's say in March or April, everybody was scared, scared. Oh, I'm going to die. I'm going to die. I'm going to die. I remember many diabetic patients called me and said, shall I write my will? Am I going to die? That was a kind of scare. So that fear, anxiety, depression, and stress are all well-known diabetogenic factors. So that is number one reason why COVID producing diabetes indirectly because of all these stress and depression and anxiety and so on. Number two, due to the COVID itself, people are staying indoors. So what happened? Not so much now, but those days people did stay indoors. So what happened? They start gorging, on whatever they can. It's a kind of release phenomenon. They start overeating, this, that. They're blaming everything. I can't get vegetables. I can't go to grocery. I can't go to this. So they start eating all kinds of foods, fast foods, this, that. After some time, even that became not available, but luckily for us. But at that time, there was a binge eating. More than that, they couldn't do their exercise. And therefore, physical activity went down, the weights went up. There's clear evidence that obesity levels increased during the period. Obesity is one of the most important causes of diabetes. So COVID, again, indirectly producing this. Number three, when you're admitted with COVID in the hospital, uh, one of the standard treatments for those who are little seriously ill with COVID is steroids. So when you give steroids, steroid-induced diabetes is a very well-known phenomenon. It's one of the commonest drugs to produce diabetes. In fact, almost everybody's sugar will go up. If you and I got it, even assuming you don't have diabetes, your sugar will definitely go up with steroid because steroid is an anti-insulin hormone. So if you inject it, the insulin won't work temporarily, and therefore your sugar levels will go up. For those who have pre-diabetes, that is enough to trigger diabetes. If you have diabetes, even well controlled, it will become uncontrolled after this. And those who don't have anything may become pre-diabetic or diabetic just because of this. It may be a temporary thing. If you stop the steroids, it may go away. In some, it doesn't go away because once it triggers, it will stay. It is in waiting for an opportunity to come, and then the steroids come. That's the third mechanism. The fourth mechanism is direct injury to the beta cells. Now, this is being researched a lot, and I'm also part of that research. We have not been able to directly prove it, but we cannot disprove it also, that the virus gets into the pancreas and then goes and damages the beta cells and then produces permanent insulin dependent kind of diabetes. Do you have proof for it? Recently, we got some proof. When I say we, it's not me. There's a paper published in Nature Metabolism, a very top ranking journal, where they looked at 4 people who passed away with COVID and diabetes and opened up the pancreas. They did not know that they had diabetes earlier. Then after COVID, they developed diabetes. When they died, they did a postmortem. And right inside the pancreas, where the beta cells are there, they found these COVID virus particles inside. They also found that the beta cells are all been destroyed. And then they gave some drugs as experimental based on that. They took beta cells and then injected virus into it, and immediately they destroyed all the cells. And then they took some medicines which are used for treatment of COVID and injected it along with that, and they found not so much of destruction to the beta cells. And so it is fairly clear that there must be a small subset of people who are developing diabetes due to COVID-19 itself. So in 4 mechanisms, you can say that COVID-19 can produce diabetes. And of course, if you get diabetes because your immunity is lower to that extent, for COVID-19, it's like a free run. It can just go in and do all the damage. For example, it's like, let's say there's an enemy invading. I'll give you 2 examples. One is like enemy is attacking us, okay? And our army is very weak. They'll run through our army and invade. Whereas you have a strong army, either they won't be able to invade or the invasion is only a little bit because we are also giving a tough fight. So they'll also get killed, we'll also get killed. In the process, there'll be something, but they don't enter into the territory so much. So a weak body, like a diabetic body, is where the virus just has a free run. It'll go inside, do whatever havoc it wants, and it'll produce what is called as a hyper-inflammatory response. It'll start triggering all kinds of, like pulling the wrong buttons. So it'll start, doing all kinds of things, and therefore this cytokine storm is what results in it'll go and damage the lung, the heart, the kidney, you name it. Every organ it will go and damage, and it can produce, even death. And that's where the hypoxia, you're not able to breathe, and clots, big clots start forming. All these come because of this uncontrolled thing. And in people with diabetes, this can happen. One more example I'll give you people to understand is, suppose you have a matchstick and you light the match and you put it on the floor. In a few minutes, if it's under this fan, in 2 seconds, it'll be it'll go out, because it cannot. It needs something to make it go on for some more time, and the air is like countering that, and the match cannot be there lit for a long time. Suppose, on the other hand, the fan is there, everything is there, but I put this match, I light it and put it. But where I put it there, let's say there was some kerosene there, or some diesel or petrol or something. Imagine the whole room will catch fire. Same match only, same stick only, but because there's this inflammable material there, not only the whole room, the whole house may catch fire. So the damage is still the same. The virus is still the same. The match is still the same, but the damage it causes is much more. That is what is like a diabetic thing. It's like providing the fuel, providing the kerosene, providing the thing for the virus to grow. So that's the connection between COVID-19 and diabetes. And the bottom line is, you have to keep your sugars under good control. Once you control your diabetes very well, your immunity improves. You may not come to like a non-diabetic value, but almost 90% of the immunity, or the 95% of the immunity of a non-diabetic person, you will get by controlling your diabetes.
Dr. Mohan, thank you so much. I think if people don't get the fact that diabetes is like kerosene in the body, I don't know what is going to help them in the future. But having said that, a few questions I have related to the answers that you were giving. One is a very basic, and I think it's been repeated, but I don't mind repeating it again. We talked, the first wave came, the second wave came, everybody said, okay, people with diabetes, hypertension, etc., need to be safer. Now we've gone beyond that. Everybody is going to get COVID, and that's the assumption one goes with, right? People with diabetes already are following a protocol, the ones who know that they are diabetic. What further can they do so that even if they were to get the disease, the situation does not go so severe where they need to be hospitalized, and the severity of an eventuality which we don't want to talk about, but that may not rise. And similar is the case when you don't know and you haven't got yourself tested. What is the message that you want to give to these people?
So there are two different scenarios. Once you know that you have got a problem, then you can address it. And in fact, I'm very pleased that when this COVID first came, there were some mathematical projections, and they said that this HbA1c test, a 3 months control test, it should be below 5.6 is normal, but below 7, if you get it also, is good enough for diabetic patients. So there was a projection one of the Indian doctors wrote, saying that the HbA1c will go up at least 4%. So from 8, it will go to 12, and 12, it will go to 16. And that's going to be the effect of COVID and the lockdown. And just lockdown itself, they said, will result in that. So we said, let's test it out. So we called 3,000 of our patients during the lockdown and asked them, when did you, do that? We knew that they had come to us at a particular, because we have electronic records. So we knew they'd come 3-4 months before that, and we knew the HbA1c results. So we called them and said, have you had your HbA1c done now during this period, during the lockdown? So around June, July, we called them. So already about 3 months had gone. So that had to be that effect of that time. And we were surprised to find that the HbA1c of these people during the COVID, I'm not saying they got COVID, but I'm saying of my diabetic patients who are under our care, during that COVID lockdown period, it actually decreased by 0.5%. We completely disproved all those mathematical calculations saying it will go up by 4%. So, and people wouldn't believe it initially, saying, how can it be, how can your patients alone improve? So I said, it's effective education. We have educated them, told them what to do. Plus, maybe our patients are of a slightly higher socioeconomic status. Maybe they are, middle class and above. And so they've been reading every day, deaths and this and that, and that's frightened them. And therefore, they have been following a little bit more strict diet, and even inside the house, walking, even if they can't go out, taking their medicines, testing more. The testing of this SMBG, this self-monitoring blood glucose, it went up from 13% of people who normally test to 52% of people who test. That's like a 3-4 times higher jump. People want to know. So that answers your question about whether you are controlled or not in a diabetic patient. Many of them had their HbA1cs done. They let me check it because we kept giving out messages saying 7%, 7%. You'll be like a non-diabetic person if you do that. So people went, let me check what it is. And if it's high, they called us and said, what do we do? How do I get it to below 7%? So that was one set of people. But I must admit that there was another set of people who just didn't care. As it is, they are the losers. For everything, they'll have an excuse. One party wins, they will do badly. If the other party wins, also they'll do badly because they just want some excuse not to follow. So those people, they're the losers. What they did was, they went hell and haywire. We'll stop everything now. So even the medicine they're taking, they stop. Suicide, saying that anyway we're going to die, so might as well stop everything and we'll just enjoy ourselves. So that way they went, and some of them did very badly. And those are people, some of them whom we lost also during. Otherwise, very few of my diabetic patients actually died. Believe it or not, we have thousands of, lakhs of patients totally. The people who actually died due to COVID in my entire practice is very few. It's a great credit to how well they have controlled. I can't say that they didn't get COVID. As I said, 35% of people have COVID antibody positive. So I mean that many people have got it. But the number of deaths were very, very, very few. Of course, now most of them have got vaccinated also. So the good news is that if you look after yourself, you can reduce the risk to that of a non-diabetic person, which is great because very few non-diabetic people without comorbidities and all that die. If that happens in some old age and other morbidities and things like that. Of course, in the second wave, some youngsters are dying. We'll talk about that later. But then the other question you asked was, how do people know whether they have diabetes or not? Now, well, if they have a family history of diabetes, suppose the father has it, mother has it, brother has it, somebody has it, you also should be aware that you have a very high risk of developing diabetes. And if you've not checked so far, why don't you check now? Because this is the time to check. And with a glucometer, you can simply check at home. At least severe diabetes, you can pick up then. Otherwise, if you're able to go to a lab and do a proper test to find out, now's the time to do it, because if at all you have it, even if you have pre-diabetes, you can get it under control. In fact, what I have only today morning on both on Twitter as well as on Facebook, I have put out a statement which a lot of people seem to have liked. I said, look, mucormycosis, we'll talk about that also later. I said, see, COVID-19 people with diabetes do badly. We know that. We know that a significant number of people have diabetes. Okay. We know that their sugars are not under control. Today, we know there's one more danger, is black fungus and mucormycosis and all that coming. That also we know. With all this, what are we waiting for? What are we really waiting for? If there is one priority that the whole country can decide, and this is a known enemy, diabetes is a known enemy. Otherwise, you don't know who is going to get what. Now we know people with diabetes. What are we waiting for? So I propose today, just today, this morning, I just announced saying that in both on Twitter and Facebook, saying, you know what, I have an idea. Let's declare June as the glucose control month for India. Okay, India needs it more than anyone else. Let everybody who has diabetes somewhere in the country focus on this. This 1 month you spend focusing on your diabetes and seeing that everyone, whether you're a doctor treating it or you're a parent with the thing or a sibling with the thing or you yourself have it or whoever you are, the prevalence is so high that everybody, I'm sure your family, somebody will have diabetes. It's so common that there's no family without diabetes now. Everybody carry this message, like we did with the freedom, struggle kind of thing. Spread this message. And let's say that this month, normally November 14, World Diabetes Day, we can't wait till November. It's too far in the pandemic. Let's make June itself, the month that we're going to, and this whole month, the whole country, focuses on controlling diabetes. With that itself, will blunt the COVID-19, What a simple thing to do. Just take your medicines, follow your diet, do some exercise, sleep well, build up your immunity that way, eat healthy, eat some good vegetables and things like that. Whatever you can do, whatever you've been to do, yoga, do pranayama, do whatever you want. This whole month you focus on that. You will just cut the cycle completely. Mucormycosis will go. Okay. And COVID-19 deaths will come down due to diabetes. And it's so simple. It's not like treating cancer. You need MRI. You need just take your glucometer, check it. You have it at home. Don't have it, buy one. It's not very expensive. Do that or go to a lab, do something, but focus on this. In the whole month, let's all join together. So immediately, I had a lot of responses from my colleagues saying, sir, we are all in it. You take the lead. We are all in it. Let's make this a mass movement for India. Because even the Prime Minister yesterday has said that mucormycosis controlled diabetes. Well, he has said that yesterday. Okay. Only thing is the message is not gone loud and clear that if we do that, how much benefit we can get out of it. So on a war footing, this has to be done. And if you do that, you can definitely do it. And again, if you find out if you're diabetic or not, you don't need very big investigations and so on. How much time does it take to check a glucose? 5 seconds it takes. Just a drop of blood. That's all you know. And you can easily find out.
Thank you so much for that. And I think what you said is something that we as Famhealth would also love to look into. Maybe do a diabetes month, a challenge of sorts,
Absolutely.
which everybody can participate. And then
Correct.
everybody needs to make sure that every morning they report and they have somebody to report to say, look,
Correct.
I've achieved it today.
Correct.
I think
Correct.
even if we can affect 10 people or 10,000 or 10 lakh,
Yeah.
it would be a big difference and a dent in making people's lives. So thank you. I think it's a fantastic, and maybe we can work with you on that. Going back to what we were discussing, I think COVID is the larger issue at hand, and it's not going anywhere soon. A few things that I do have is one is that again pneumonia complication again is being talked and seen severely in diabetic patients. So when and how does this pneumonia set in, and why diabetes again?
So pneumonia is a bacterial infection. It is not, of course, you can get viral pneumonias, but more common is streptococcal pneumonia, or what you call as community-acquired pneumonia. These are secondary bacterial infection. But remember that, and these are amenable to treatment, and they're amenable to prevention also. So there are separate vaccinations called as pneumococcal vaccination. And the beauty about the pneumococcal vaccination, unlike COVID or unlike influenza or any other thing, it's normally once in a lifetime. It's a simple jab. And unlike the COVID vaccination, which at least they're talking about some side effect, till today, I have not touched wood, I have not seen a single side effect after pneumococcal vaccination. So last year itself, we started. Of course, the guidelines were there even before that. But last year, when COVID started, when we had no COVID vaccination, what we started was we started a movement saying that let's do two other vaccinations. One is influenza vaccination, because influenza is also coronavirus. Remember that. It's very closely related to COVID. In fact, the symptoms are very similar also. The virus is also very, that's why this is called as a novel coronavirus, the COVID-19 one. Okay, SARS-CoV-2 we call it. So, so we said, let's do the influenza vaccination, which is of course once a year. And let us do the pneumococcal vaccination also, because influenza also can get a secondary pneumonia. Okay. And especially in older people, one of the commonest cause of death is pneumonia. And once you take this pneumococcal vaccination, you're almost definite for life, you're protected from a pneumococcal pneumonia death. Even if you get the pneumonia, you will not, die from it, or it won't become severe. So that is one campaign that we started last year. Thousands of people took it. Surprisingly, those who took the influenza vaccine, I didn't guarantee them saying it will have anything to do with COVID, and I'm still not saying it because I don't think I have the proof for it and may not be correct. But from anecdotal experience, what we felt was that even before the COVID vaccine came, people who took the influenza vaccine, when they got COVID, my diabetic patients, they did well. They didn't have any symptoms. It went off like a small flu. And they were convinced it's because they took the influenza vaccine. Because I didn't promise them, I didn't tell them anything, and I didn't tell them, yeah, I take the credit because I gave you influenza vaccine. But it's not surprising because a very similar one and some kind of cross immunity must have developed. And that's the only thing we could do at that time. There's a very well-known, standardized, safe vaccination. So this is something which for diabetic patients we started doing. Now, when the COVID vaccination came, of course, we started giving the COVID vaccination as well. So pneumonia, coming back to question, I think pneumonia is something which we can very easily prevent with this pneumococcal vaccination. And remember, it's only once in a lifetime. And you generally don't need it unless you've taken it when you're very young, say 20, 30 years old. When you cross 60, they say take it once more. But you have crossed 50, 60 and have taken it for your life, you're protected. And it's a very simple injection, nothing in it, not very expensive, you can easily take it. So that is something which you can do and can prevent all these bacterial pneumonia and the deaths due to that.
Dr. Mohan, can this pneumococcal vaccine be taken by young kids, especially the ones with type 1 diabetes? Can they also?
Yeah, we've been giving them. So any diabetic patient, even type 1 diabetic, juvenile diabetics, we don't give it that, say, to toddlers and to very young people. But anyone adolescent and above can take it, especially if they have diabetes. If they have diabetes, any age is not a bar. You can give it. For non-diabetic people, they say generally in adults it is sufficient. Above 30 years and all that sufficient. Above 60, the whole population should take it, whether you're diabetic or not diabetic. If anybody you know is above 60 years of age, ask them to take the pneumococcal vaccine. They don't even have to wait for diabetes. You
Very
can.
nice. Okay, that's something really new and interesting, and I think we can start at home. I probably can ask my parents to start taking
Yeah,
the
yeah, yeah, sure.
pneumonia. Moving forward, you talked a lot about the use of in the treatment process. We were discussing just before we started the discussion on steroids. That seems to have become one of the common forms of treatment where COVID is concerned. Having said that, steroids has a lot of negatives attached to it as well. One of them, is, of course, clearly seen is the high rise in blood sugar levels of patients. The second thing that's increasingly being talked about is the black fungus in reference to steroids. So give us a little information on this, Dr. Mohan. What really is happening and how are we going to take care of this?
Let me step back and say, how did steroids get into COVID-19? It's not something you normally associate with a viral illness because virus is supposed to be made worse by taking steroids. So normally we'll stay away from steroids if virus, suppose influenza, you don't go and give a steroid at that time. So normally we stay away from that. What happened was in the first few months, March, April, May, what we thought was we would see pictures on the CT scan and we said, oh, this is like a pneumonia, but it's not a viral pneumonia. It's a kind of pneumonia. And therefore, antibiotics were given and all kinds of other drugs were given. And when the oxygen saturation started going down, straight away onto a ventilator they were put. You'll remember that, thousands and thousands of ventilators were bought and made and new types of ventilators. The whole focus was on ventilators in the first 3-4 months, you remember correctly. Then came some very important contributions from Italy, actually, where they did postmortem. Now, the thing is, in our country, we don't do postmortems. When somebody dies, also, we don't know why they died because it's not in our culture to do postmortems. Postmortems tell you a lot. They will tell you what did that person die from. So it's very important to do that. In Italy, they did a series of postmortems and they thought they'll find the lung, completely filled with all pneumonic patches and all that. When they opened up, they found blood clots, actually blood clots in the lung, which they were not expecting. Even the what is picked up in the CT scan was actually blood clots, which you could not, like a shadow it is, so you really cannot make out. They thought it's a pneumonic patch. So there was no pneumonia at all. In fact, it was these clotting, micro clotting as well as macro clotting. Some of the places, big clots were there. So they said, oh, this is a clotting mechanism which is taking place. So something the virus is doing, it's sparking off a inflammatory reaction, something like a danger, some signal it is sending, asking the blood to clot. And so it is clotting in all kinds of places. So it produces heart attacks by clotting and things, strokes. So many strokes came due to that. Even young people, some of them developed strokes after that. Kidney, blood circulation getting blocked, liver, all kinds of places. They found these clots. So they said, okay, now what we have to do is to give anticoagulants. So they started giving anticoagulants, which is still there. Even now, the anticoagulant therapy is one of the accepted therapies because that's how people die due to these clots. Then what they found was that in the ICU, once they discovered this, they found that something is going wrong with the immunity inside the body. The immunity is totally going haywire, and this hyper-inflammatory response. They're able to see that suddenly all kinds of inflammatory things are going on, which is uncontrolled. So you need something to suppress that. And that is how the steroids came in. So they did a trial. In the UK, they did a trial. It's called as a recovery trial. So this came out somewhere in August, September, I think it came out. Saying till then nobody had used steroids for COVID. Serious case, advanced case, nowhere. Steroids were not even thought of. In this recovery trial, what they did was they put people on steroids and they found dramatic recovery. People who were dying suddenly coming to life, oxygen levels going up, saturation improving. So they said this is an inflammation, and so we have to use. It's like it reminds me the way we are learning about COVID. It's like the six blind men examining the elephant. So one fellow catches a tail and he says, "Oh, it's like a rope." Another fellow sees a trunk and he says, no, it's like a snake, it kind of winds around and it's like a big snake. Another fellow sees a trunk and he says, no, it's like a tree. Elephant is like a tree. They were all right and they were all wrong because they were only seeing part of it. I think COVID has been like that. First we see something, then we say something. Because this is the first time human beings are seeing it. We are being blamed. Imagine, including some gurus and all that, blaming us, saying, you all are stupid. We are stupid because we're seeing it for the first time. It's not that we are treated it all our life. We are, as much as you know about COVID, we also know about COVID because we are also treating it for the first time. We are not born with when we went to medical college, there's nothing called COVID. So how do we learn? Only when the cases come, only suddenly case lands up in the thing and he's sick. What do? We have to do something with all our knowledge. Oh, give him oxygen, give him this. That's all we can do. We don't have a manual to tell us what to do. The manual will be written after 1 or 2 years. It's too late. But how quickly still people have realized, no, this is not this. It's oxygen to be given. It's anticoagulant to be given. Stop putting people on ventilator. People on ventilator are not doing well. Quick, that is where science comes in. Quick analysis, making mistakes, but knowing that we made mistakes, correcting the mistake and saying, this is not the way to go. That's the way to go. And then quickly, and then the vaccine also came like that. In record time, normally a vaccine takes 10 years. The fastest a vaccine has come is 4.5 years before this COVID came. Here we are, not even 1 year over, and 30% of the world has already got the vaccine. It's already produced a vaccine, 6 different people in 6 different ways. Trials are over, vaccine has come, and the population also has been done. I mean, it's ingenious how it has been done. I mean, I salute the scientists who did this. How are they even doing it? Because all the past thing, using computerized knowledge, using artificial intelligence, everything they put into it to make this is a success. So coming back to the recovery trial, so they tried that and they found that it worked. So having done that, they laid the criteria and said, use dexamethasone, use 6 milligrams, use it for 10 days, use it after the first 1 week. First 1 week, please don't use it. Use it in the second week. When you're in ICU, when you're sick, that's the only time when you should use it. If life is in danger, then you use steroids because it is life-threatening. Because at that stage, you don't mind if the sugar goes up or something goes up. You really don't mind. You're struggling with the patient and saving the life. And there, steroid becomes not only for this, any condition, blood pressure is dropping, you give steroids. If something else is going wrong, you use steroids. Steroids are all, it's like a sarva roga nivarani kind of a thing. Anything where your life is in danger, you give steroids. And it works. That's how it works. So that is how steroids came. But then what happened was, many countries, I think including India, people started thinking that it's a prevention for COVID or it's a panacea. Oh, COVID is life-saving. So if I take COVID, I won't get COVID. If I take steroid, I won't get COVID. Nothing can be further from the truth. You're actually promoting the virus and inviting the guy and saying, come, I'm clearing the road for you. Now you walk in, without any. So steroid should not be used as a prevention. It is not a prophylaxis. It should definitely not be used in the first 1 week because that's when the virus is multiplying. If at all you're in hospital, is the only time when you can use a steroid, not at home. I find a lot of people at home taking steroids in the second week. Now it's second week, now I'll take steroid. You should be in hospital, you're taking steroids, okay? If properly used, the steroids are good. As you mentioned, there are many side effects of steroids. One of which is your sugar will definitely go up. Even in a non-diabetic person, completely non-diabetic, inject the steroid in this dose, and within 2-3 hours, your sugar will go up. That's a natural phenomenon. I know of a former VIP whom I was treating who was not diabetic in Tamil Nadu. And I used to be frequently called because the sugar goes up. He was on steroids for some skin condition or something. And every time I look at it, the rest of the day is completely normal. But when he takes that steroid for 3 hours, it goes up. And the question was, should we give insulin for that? I said, you can't. He's an older person. You simply cannot give steroid. 3 hours later, it's coming down. Just leave it and it's coming back to normal. It's a normal physiological response of his body. So don't do anything to do that. But in the doses that these people are giving for COVID is much higher. So it won't be just for a few hours. It may be half the day, it may be high. So you might need to give insulin, and tablets will not work at that time. You have to give insulin. Insulin is like a counter to steroids. At least it's glucose levels. So you can give that and prevent that very high spiking of glucose you can prevent. But steroids also reduce your immunity to a large extent. That's why it's given, to reduce your hyperimmune response only, it is given. So steroids are a double-edged sword, as you said, can be life-saving, can have a lot of side effects. Sugar is one of the main things. And as you mentioned, the black fungus. Now, when you have steroid, your immunity is going down. So suppose you already have a little fungus in the nose and so on. Normally, it will just die off. It's a harmless fungus, it will go off. But again, like the COVID virus, if you are inviting the fungus to grow, it will grow. It will grow. And see, I'll give you I'll tell you what this fungus is like. It's like this mold. And if you take bread, stale bread. Have you seen stale bread? You keep it out. What happens? A green kind of color comes on it, isn't it? That's a fungus. A fungus is coming because it's moist. You kept it out. Air is there. So that's the oxygen part. Okay. So air is there. So the fungus multiplies in that air. It's kept out. You keep in the fridge, you won't get any fungus. In a controlled atmosphere, you're not exposing it to air and you're keeping it in a controlled thing. You won't get fungus if you keep it in that thing. Here, the similar situation, you're lowering the immunity, then you're giving oxygen, then you're giving a steroid to do that, plus you've got uncontrolled diabetes. So it's a good culture medium for this fungus to keep growing. So it hits the nose first, produces some blackish discoloration and all that. From there, it goes to the eyes. From there, the eye can get affected, get paralyzed, swollen, protruding out, red. Then from there, it can, through the sinuses here, there are veins here, straight into the brain. Then once it goes into the brain, it's almost always fatal. And even otherwise, the mortality is quite high. So this black fungus is something which comes in this situation of uncontrolled diabetes with or without steroids in an ICU kind of a setting where the fungus is, multiplying and perhaps a little bit of unhygienic conditions. They say the moisturizer which is used in the humidifier, there, if that water is not clean, you can have fungus in that. Or the tubing, that can have a little fungus. From there, it can spread. So that is what this mucormycosis or black fungus is all
about. Okay. Dr. Mohan, you mentioned that steroids are being given and can be given as a treatment for people with slightly severe and inflammation starts and the entire body starts behaving in a manner beyond your control. Now, if somebody is already on steroids and being given and happens to be diabetic, or like you said, it increases, and you have to put them on insulin, what is the protocol of administering the insulin? How often should it be checked for a patient who's on steroids? Should it be checked 3 times in a day or every day, once in the morning? Even though it's the hospital staff and you trust that they know what they're doing, there needs to be some kind of a protocol that needs to be followed.
Yeah, we have to test the sugar several times a day. And, I was telling you about that VIP of my streeting. So similarly, unless you test different times of the day, so normally itself, we ask diabetic patient to check once, twice, thrice a day. I think in a hospital, there are two things you can do. One is, every 2-3 hours, you can already there could be something going from there itself, take a drop and then put it. Or use a finger stick and then do that. Every 2 to 3 hours, maintain just like you check the BP or the pulse or pulse oximeter and so on. Like that, do the glucose is today called as the fifth vital sign. So pulse is one, blood pressure is one, respiration is one, temperature is the fourth, and the fifth is glucose. So glucose is the fifth vital sign in any ICU or in any hospital setting. So when you're measuring all of those several times a day, why wouldn't you measure glucose several times a day? So you must do that. Today, we've got small patches, small sensors. You can put it on your arm, like a coin, it's like a 2 rupee coin or like one of those carom board coins, even thinner than that. So it's made out of plastic. So you just put it on your arm and then you activate it with a sensor. So you just activate it. And once you do that, you get continuous glucose readings every minute, every 2 minutes. You can, anytime you want, without poking the patient, you can just get that. That you can link it to actually to a cell phone or to a long distance thing. And just like you monitor on a BP, on the screen in an ICU, you measure the pulse and the blood pressure and the respiration and even the PO2. You can measure all that on a monitor now of the ventilator, and near that all these screens which gives you all these monitors. You can include glucose also in that. So you can see the glucose levels going on throughout the day. So even if the blood glucose is normal, let's say 8 o'clock, 9 o'clock, 10 o'clock, it's normal. Now at 10 o'clock, you give this bolus of, or 11 o'clock, you give the bolus of the steroid. Within a couple of hours, it will start rising. So the blood glucose level rises, and then it will follow a kind of a pattern which will vary from patient to patient. Depends on the initial response, and depends on your insulin level in the body, and it depends on so many other things. But what will happen is it will go. So it'll go up, and then for 5, 6, 7, 8 hours, it may remain high. And then automatically it will come down. Even if you don't give anything, the steroid effect cannot go on. If it goes on, then you don't need next day steroid. No? So it will only work for about half a day or quarter a day or something like that. So at that time, once you know that pattern in the ICU and say, oh, this is when it's going to go up, before that, you can give the insulin. So that when you give the insulin, the steroid does not allowing the sugar to go up, and you can blunt it and make it normal. So first day you give the insulin, and there's no fixed dose, because each one person may need 6 units of insulin, another person may need 10 units of insulin, another person may need 14 units of insulin. So you give the first small dose and see what happens one day. Oh, it's not enough, it's still going up. I'll give another 2 or 4 units. So like this, we can control the blood glucose levels and keep it completely under control, so that even after the steroid, it doesn't go up. And this can be individualized. If you already have diabetes, then throughout the day it may be high, and then with the steroid it may go even high. Then you may need multiple doses of insulin to control. So there's no individualized pattern. There is no single one for everyone. It has to be individualized, but it can be very easily done if you have a diabetologist on board. I would say in all ICUs where you're treating COVID cases, and if diabetes is there, steroids are being used, include a diabetologist along with that. He will fix it for you. He'll come and fix the doses for you, so that that part is taken care of. Most often what happens is, in the ICU, they focus on other things. They check the oxygen, they check this, check that. They forget about the glucose part. And that could be another reason why this mucormycosis spread. At that time, their worry is not glucose. They're worried about so many other things that they forget about this. Ultimately, they end up with more severe problems because of uncontrolled diabetes.
Yeah, so I think from what you've been saying, every single marker is so essential and so important to note, because, like you said, there's not enough research being done to see why the patient is dying in the first place, or
Yes.
what reason the complication moves up. One more thing, there are lots of community questions coming up, and I just will quickly take those one after the other before we move to our next set of questions. You had mentioned that last year, because your patients were in a closed environment, there was one set of research that was done to say that it might go up their blood sugar, but it actually, the ones who monitored it managed it well. What effect has the lockdown, once it opened last year, November onwards, and when all these last 6 months have been crazy and people went berserk, going out, exposing themselves, etc.? What effect has it had on diabetes blood sugar patients? And what is the effect essentially of the levels of pollution, etc.? Has it increased the cases of diabetes? Blood sugar levels, have they gone up? How has that worked?
So the pollution story is relatively new, because pollution we had linked to respiratory disease, to asthma, allergies, bronchitis, even to some forms of lung cancer, pneumonia. This is what generally we had linked pollution to. More recently, even 2, 3 years ago, not after COVID and so on, even a couple of years ago, when we were part of this global burden of disease study, GBD study, when we started looking at all the risk factors for diabetes, like well-known ones, family history, obesity, lack of exercise, eating wrong food, stress, this, that. Beyond all that, in urban areas, there was an unexplained, higher risk of diabetes compared to rural areas. So then when we started looking, we found that pollution is one of the causes of diabetes. At that time, in one of the papers, we suggested that 4% of all diabetes is due to pollution. Okay. So as a risk factor for diabetes, here is a new one coming up, pollution. Because when you have pollution, or there is something else which can occur, not just the air pollution and smoke and so on, but also other things like plastics, bisphenols, we call them as bisphenols. So you take always in plastic tumblers and plastic bottles, and these things also have some toxic effects, and they can produce, especially what is called as bisphenol, BSA, we call it BSP. So this BSP, what it does is it acts as an endocrine disruptor. So it interferes with the insulin production, insulin action, and there's a lot of things coming up that these endocrine disruptors can be an independent cause of diabetes, apart from obesity, lack of exercise, and all that. So these are new things which are coming up. There are also some suggestions that fertilizers and the pesticides which are used, these are all new etiology for diabetes, which are coming up, which we never thought of earlier. So there are a number of things like this which can produce diabetes, but they are all preventable, So if you reduce the pollution level, that much diabetes can be controlled. If you wash all your vegetables properly, remove the pesticides, probably one more can be removed. So these are newer causes of diabetes, and these can be very easily controlled.
Dr. Mohan, another comorbidity, which is hypertension and heart disease, is also very closely linked to people getting severe condition with COVID. So we have a question from the community. Somebody wants to know, do more heart patients have COVID or more diabetics have COVID?
It's not that heart patients have COVID or diabetic patients have COVID. Who does badly if you get COVID? That is the right question. Does a diabetic patient do worse if you have COVID, or does a heart patient do worse if you have COVID? Well, honestly, there were some statistics published from Wuhan, then some from US, some from Italy, some from Spain. In India, we had very patchy data, so I can't give you the Indian data. So because most people are so busy handling the COVID, they're not been able to collect data and publish it and so on. Because most of them go to government hospitals where the load is too high. But there are some papers coming out as well. And I think one paper has been published in Science, actually, from India. But the general thing is this, that if you look at overall causes of death, total mortality, if you see, as I said, it's about 1 to 2%. Actually speaking, if you include all the unknown cases and so on, it comes down to less than 1%, only about 0.5%, which means 1 in 200 COVID cases who are treated may die. The 199 are going to escape. It's this 1 in 200 that we are talking about, all these deaths that we are seeing. So if you take the average as say 0.5%, 1% overall, among diabetic patients, about 7%, 7.5% of all the diabetic patients where they have data. Again, there will be many diabetic patients who did not even know that they had it. So it's probably a little lower, but let's take the same denominator. So it's about 2 to 3 times higher in diabetic patients. Among heart patients, it was actually 10.5%. So because they already have a heart disease, and now if they get burdened with the COVID also, as it is their condition, definitely heart disease by itself is worse than just diabetes. No? But many of those heart disease patients could have had diabetes also, which they are not taking into account. So diabetes itself, the heart disease itself may be due to diabetes. So indirectly, the diabetes may be contributing. But if you take them as separate things, diabetes, heart disease, definitely heart disease will go on top. Even more than that is old age. So if you take people above 80 years of age, 85 years of age, death rates are quite high. It's about 10% of all admitted patients. So 1 in 10 have a tendency to die. So old age, heart disease. Then if you have other chronic pulmonary, obstructive pulmonary disease, COPD, as it is your lung is bad. You've got emphysema, you've got asthma, you've got chronic bronchitis, you've got chronic obstructive pulmonary disease, where the lung is not functioning. Now you go and get COVID on top of that. Obviously, you won't do so well. And then, of course, diabetes and obesity. I didn't mention obesity at all. Obesity is a very strong risk factor for deaths. And the reason for that is that when you are obese, massively, I'm not talking about a 5 kg overweight. I'm talking about somebody with 100 kilos, 120 kilos, really obese people. Now, when you have that much obesity, your lung capacity is very poor. Your oxygenation is very, very poor. If you measure your oxygen, even without COVID, it will be bad. Your oxygen saturation may be 90 or 88 or 90 or 92, even without COVID, because your lung expansion is not there because so much of obesity. And also they have obstructive sleep apnea. They don't sleep properly. They get snoring, so much of snoring that in the night, the respiration is not normal. So they feel tired in the morning. They feel sleepy in the morning. They don't get good quality sleep. So because of that, also their immunity is very low. And so these obese people, when they get COVID, their lung cannot expand at all. And so the death rates due to massive obesity is very high. So again, showing that why you should not be overweight, and if you should try to reduce, all those are overweight. This is another message, public health message, that all those are obese. You have another reason to lose weight apart from everything else. One more, COVID is one more, kind of an incentive for you to lose weight.
I think hopefully COVID is going to teach the world that living healthy cannot be a
Correct,
one-time
correct.
thing. It has to be consistent in life. Going back to we were discussing the black fungus earlier, and it seems to be the only thing in newspapers and in the media right now. Black fungus as a manifestation existed for a long time. Why is it so severe now? And why aren't we being able to control it? We obviously know what needs to be done because it has been existing, but why aren't we be able to control it as we?
First of all, it came as a surprise. I mean, even in the first wave, we were not talking about it. Maybe for two reasons. One is that probably steroids were not being used that much in the first round. It's only after August, September, when the steroid recovery trial came, that steroids were used. And probably some misuse of steroids also occurred at that time. So that could be one reason. Second reason is that the sheer number of cases are much more in India now. As we speak now, India has the largest number of cases in the world. So the sheer number. Number three, remember we ran out of oxygen. Okay, for the first time we ran out of oxygen. People are dying on the street. So wherever they got oxygen, wherever they got things, the standards were lowered. I can't say that all hospitals maintain fantastic ISO standards and everything is audited. Many of them may not even have used their ICUs for a long time. They may not have enough beds. Now every bed, every hospital, everywhere they are trying to use it. So there is some lowering of the overall hygiene standards because the sheer load. People are dying, trying to get some bed somewhere. Anywhere you get in, you get. Not all are maintaining all kinds of high standards of hospital, JCI certified and NABH certified hospitals, and they're not going into that kind of thing. So the quality standards which are maintained may not be very good. Beyond all that, because this high dose of steroids being used and the already background of population of diabetics who are a lot of them having uncontrolled diabetes, and you said many may not even know about it. 50% of people in India really don't know that they have diabetes. 50%, half don't know. So suppose that guy is walked into the hospital with COVID now, he'll be pumped with steroids and already sugar will be very high and now it's going to go for a 6 and he's not had a chance even to control his diabetes. All this could be reasons. I'm also just hypothesizing. I have no proof whatsoever, but I'm just putting it out in case I'm wrong. I'll be happy to be proved wrong. Is it because we're using industrial oxygen and so on when there's no oxygen supply? Okay, use whatever oxygen is available. Is that oxygen industrial oxygen? I'm not the expert in oxygen, but is that industrial oxygen of the same medical quality of the oxygen, medical oxygen has been prepared for human use, or is it not purified to that extent? And the tubings through which they come, the industrial oxygens and the cylinders which we make them or whatever, are they of the same quality and the standard as for the human use oxygen? I'm just throwing this open because I'm hoping that the answer lies there. If so, we can fix it easily. I may be completely wrong, and I hope I'm wrong. Then I have no problem about it. I'm just thinking, why is this occurring? And thinking laterally and saying, is it because suddenly we didn't have it in the first phase? Other countries have not had it. What is it we have done differently? We did all these things. We tried to open up all kinds of oxygen parlors and oxygen. I find people proudly advertising that they mean it well, of course. So I have no thing. I've got an auto in which I fitted oxygen and I'm going around. On the road, can you imagine what all muck and fungus will be there on the road? Imagine that auto, whether it's cleaned or not. And here you're putting somebody there and giving nose through the nose, you're giving oxygen in an auto. What's going to happen to that person, although they mean well. Similarly, a bus carrying oxygen, what's the standard of the bus? Is that where people should be lying and taking oxygen? But these are meant well, but may end up backfiring. So you have to be very careful when you lower the standards. I'm one for always maintaining high quality of standards because we're playing human lives, and therefore we have to be very, very careful about that. And so we should plug the holes. If it is diabetes, yes, let's control the diabetes. If it is excessive use of steroids, let's reduce it. We learned the lesson. Let's reduce it now and say we'll use only a fixed protocol, only for 10 days, only for the thing. Number three, we'll maintain very high standards inside the ICU, inside the hospital. We'll clean our tubing, we'll clean the humidifier, we'll clean the water that's going, we'll clean everything. We will see that we'll get rid of black fungus. Once we start in that kind of war mission mode, I'm sure we'll solve it because it's not a rocket science to find out. It didn't come from somewhere. Somewhere something went wrong. And so I think we can fix it before it blows out of proportion. One thing, the government has said that it's an epidemic. I would not like to use that word epidemic. Epidemic is something which is spread from one person to another. Mucormycosis is not spread from one person to the other. COVID is spread from one person to the other, but not mucormycosis. It can only enter into your body through something. I cannot cough and give you mucormycosis. So it's not correct to call it as an epidemic of mucormycosis. We can say warning signs of mucormycosis, high incidence of mucormycosis. All this is correct, but using the term epidemic is technically wrong. We should not say it.
Dr. Mohan, before I move to the questions on vaccine, one last question is that in this second wave, as it's been termed as, we've seen a lot of complications happening closer to the 10th day of the patient being in hospital, almost on the verge of recovery, and then suddenly there is something that's happening. Is there any research, is there any talks on why that's happened? And yeah, you can take this one first.
So the second week, why it happens, is it? It's a second week where things go wrong, because the first week the virus is just settling in. So the virus comes into the body. First of all, it takes 2-3 days to have an incubation period, and then it enters into the body. And once it enters into the body, it starts spreading. And somewhere within a week, the virus can either the body gets rid of the virus, or the virus is already gone and settled into the body and gone into the cells. And thereafter, the virus can't keep on, multiplying for some extent. And then at that particular point, somewhere a viral illness is only a week long, whichever virus you have, whether it's herpes or chickenpox or anything, doesn't go on for 2 months, you don't get a chickenpox. Every virus, measles or whatever, is 5-day, 6-day virus. That's what it is. After that, when the recovery starts, you either recover and become completely all right, or by that time, your body's immunity has gone down and the virus is now triggered off some alarm systems in the body, false alarms or whatever, and inflammatory responses. It's triggered. That is what is called as a cytokine storm. It releases all kinds of harmful material from the body. And the virus is not doing it. Your body is doing it. The virus has stimulated all that. And now your body is getting confused and releasing all kinds of toxic things into the body. That is that second phase of the thing. That is when the body suddenly begins to, the oxygenation will go down and you become hypoxic, you become breathless. A second wave of fever may come. So fever will come and due to the thing and settling down. A fresh fever coming after 8th day, 9th day, 10th day is worrying. Why did that come? It's not due to the virus. There's something else happening. The body is reacting. That's a warning sign. Any breathlessness is a warning sign. Any drop in oxygen is a warning sign. So any of the feeling giddy or bluish or chest pain or any unusual symptom that you get at that time is a warning sign. And that might need immediate hospitalization. And that's where things go wrong.
Also, Dr. Mohan, why younger people, whether it's severity or deaths, we have lost too many young people in this. What is the reason behind it, and what can one do to control?
It's more in the second phase. In the first phase, it is all old people. You see the mean age at death 60, 65. Abroad is 80, 85, but our population is only 60, 65. You don't have too many people 80. So everything is 20 years advanced in India. So mean age at death in India was 58, 60, 62, 64. So in the first phase, 1 or 2 young people died. And, even young people have problems. See, young people have obesity. So obesity, I told, is one of the reasons. And it's the younger people are more obese, not the old man who's so fat. All the youngsters are today like this, at 30, they are 100 kilos in weight. And so we only see the age, we don't see the other comorbidity. A lot of young people have diabetes. A lot of young people have other diseases. A lot of young people have some genetic diseases. They have blood clotting diseases. So when it affects them and they die, this makes the news more. Because the person is young, it makes the news. So we think all young people are dying. It's not so. The young people recover very well. And in the first phase, we hardly had deaths among young people. Now, what's happened is, because the government started off with vaccinating older people, quite rightly also, older people are protected quite a bit. The youngsters, 18 to 45, was announced only from May 1st. And by the time the vaccines became short in India, so this 18 to 45 years, people have not been vaccinated. How many have been vaccinated? For the whole country, the vaccination is only some 18% or something like that. Among young people, it must be like 1%, 2% of people who have got vaccinated. So they are an unvaccinated lot. So they are at high risk now. When they get this infection, if they suppose 100 old people get affected, 100 young people get affected, those 100, none of them would have been, the young people, none of them would have been vaccinated. Out of the 100 old people, maybe 30-40% have already been vaccinated. So you will proportionately hear of a lot of young people dying, even though the old people only more are dying, if you look at total. But suddenly you're hearing of young people dying. That is what has happened. Once we finish the vaccination of all the young people, then you will not hear of straight deaths may be there, but not so many.
Coming to vaccines, I think before we went live, we were discussing how you have also vaccinated your
Yep.
entire staff, and most of your patients are listening and getting themselves vaccinated and hence getting protected.
Yeah.
How safe do diabetics become from COVID once vaccinated? If you can put some light onto that. And a little controversial question, which we've never addressed before, but in light of the new media report that came in, Covaxin versus Covishield. Is there one better than the other? If not, then why is the EU saying stuff like Covishield will get recognized and Covaxin will not get recognized, people traveling from India to abroad?
So, yeah, there are several questions within this. First of all, as far as the diabetic patient is concerned, they have this. First of all, they are not more. They will not have more side effects than people without diabetes. So we were getting a lot of vaccines until the end of April, and then suddenly the government stopped giving us, being smaller hospitals. So we did about 5,000-6,000 people we vaccinated. Touch wood, not a single person had any problem. We didn't have a single death. We didn't have one or two had fever and so on, from which they recovered. But overall, it went very smooth. And the reason is because the side effects are not 1 in 5,000 or 1 in 10,000. It's like 1 in 1 lakh, 2 lakh, 3 lakh, more like 1 in 5 lakhs. So if we had given 5 lakh people, we'd also seen 1 or 2, bad effects. We didn't give that many, so we have not seen that. So I cannot say that because nobody of my patients develop, they will never develop. There are some side effects after the vaccination, but thankfully they are very, very, very small. So it's like 0.01% or 0.001%. So that means 99.999% you're not going to get it. So for that 0.001%, are you going to stay away from taking the vaccination? Is a question. I turn it around and say, okay, if you go in a flight, there is a 0.00001% of you dying. Okay. But if you don't go on the flight, you may not have that risk. So then everybody stop flying and everybody sit at home, because then that 0.001% you can avoid, We don't even think about it, no? I used to travel, twice a week I used to be on a flight before last 1 year. I used to be twice a week I'll be on a flight. I've never thought of, oh, this one's going to crash, that one is going to crash. We take it for granted, occasionally 1 or 2 crash, We can't help it. Things do go wrong. Similarly, in vaccination, occasionally 1 or 2 people do badly. We still haven't found out why exactly they do badly. Probably they have some genetic defect, or they had some immune response which is slightly different, or they reacted very badly to the vaccination, or the body thought that it was a COVID and then developed some clot or something like that. So human biology is so varied. It's not like mathematics, not like physics. 2 plus 2 is not 4 in biology. So occasionally something will go wrong. This can happen with any vaccination. Measles vaccination, give 1 in 1 lakh people can die due to measles vaccination. Polio vaccination, something can happen. So like that, in all vaccinations, it happens. Here, it's a clotting mechanism, which is the whole thing of COVID. And that's what we're trying to do. Where if you want to produce a reaction in the body to the immune system to stimulate it, you'll have to produce something like that. Only then it is specific to COVID. Sometimes it gets exaggerated. It's not meant to get exaggerated. Sometimes it gets exaggerated. Now and therefore, my recommendation is everybody pray and everybody go and take your vaccination, because that's the only thing you have to protect yourself. As I said, among all my staff, among all the people whom I know, those who have taken the vaccination, except 1 or 2, for everything you can find an exception. Okay, if I tell you, oh, but I know of somebody who died. Yeah, he's only one. Biology, there are always exceptions. Don't go by the exception. Go by the rule. Don't pick out one guy whom in the world something happened, and for that the whole world changed because that one guy. It doesn't work like that. In biology, medicine, it doesn't work like that. We are conscious of it. We are not denying it. We are saying, yeah, occasionally things do go wrong, but what else? You have a choice. You don't have a choice. So therefore, we do that. So everybody take the vaccination. Now come to the 2 vaccination. Covishield versus Covaxin. Covaxin made in India, so there's a little bit of more government support for it because Indian product, made in India kind of a thing. Whereas the Covishield one, the Serum Institute one, is an AstraZeneca virus. It was discovered in the University of Oxford, and then AstraZeneca bought it. They licensed it and gave it to Serum Institute because Serum Institute is one of the largest manufacturers of vaccines in the world today. Therefore, they gave it to them to do, and they did a good job. They brought out the vaccine. Now, when the Covishield, the thing with the Covishield, it's been around for longer. It's a British one, and they have given it to a lot of people in the UK. They've given it. Many other European countries also, they gave it. Now, the Covaxin is a dead virus, whereas the other one is an adenovirus where the live attenuated virus is put inside. So that difference is there between the two. Okay. So in the case of Covishield, the reactions are a little bit more than the Covaxin. But on the other side, the effect is also more than Covaxin. Covaxin's effect after the first dose is only about 40% of people get, protected. After the second dose, about 60% or 70% get the effect. Maybe it goes up to 80%. But we've really not seen all the Covaxin results published. Till today, we have not seen all the phase 3 and everything. I would like to see more data on that. So my own personal opinion is that Covaxin is made in India. It's also a very good vaccine. It's more like the Chinese vaccine. Okay, it's a dead attenuated vaccine, and it's a more traditional way of producing vaccines, by the way. And so it is safe. You can take it. The effect after the first one is not at all enough. So I've seen many people after the first shot still get COVID because they've not yet been protected. After the second one, and you have to wait for 4 weeks after Covaxin. And if you take the second one, then your protection is quite good. You might need a third one. We don't know. Till now, they haven't said, but Covaxin being weak, I won't be surprised if after 6 months they say you need one more of Covaxin. Okay. Because that much immunity, maybe you will get. This is completely off-label. It's not approved. I'm just saying. I'm just guessing that probably after some time they'll say, just like influenza, no, take it every year. By the time this year is over, they may say take one more. As far as Covishield is concerned, after the first one itself, the effect is about 60%, and after the second one, it's almost matching the Pfizer. Pfizer they're claiming 90%. Here some 84 or 85%, something like that. Pfizer also, being an adenovirus, Pfizer, Moderna, and Covishield are not very different. So the Pfizer vaccine has also had some, Norway, remember 29 elderly people died after Pfizer vaccine. So some deaths have been reported, maybe in extreme ages or something. But if you see that way, almost the entire US population has received Pfizer vaccine. Almost the entire UK population has received either Covishield or they call it AstraZeneca. So either the AstraZeneca or Pfizer. The entire UK has been populated. How many people died in UK? Not many. So some clottings have been reported. Blood clots have been reported in people who have got it. Regarding Covishield, I have not seen like that kind of a thing. So it's probably a little gentler vaccine or something. But I don't think we can have much of a choice. Even if we put both together, it's not enough for India. So I don't think we are in a position to say we'll take only Covaxin, I'll take only Covishield, I'll take only this. I took Covishield, by the way, because that is what is given to us initially when it first came. I was one of the first to take. January 16th, when it was announced, suddenly I was called. And one of the hospitals, didn't get it yet, but one of the hospitals, where only 2-3 hospitals had it on the first day. And they called me and they said, we want 10 most prominent doctors in Chennai to come and take. So I said, God, so I am the guinea pig. Then they said, no, don't look at it that way. You're a role model. I said, okay, I'll come. I'll say my prayers and I'll come. I'm the first one to take it. For me, nothing happened. I didn't even get a 99 fever also I didn't get. And even after my second dose, touchwood, I didn't get anything. I was perfectly all right. So for me, it went like any other, like a small injection it was to me. Nothing happened to me. And all my family members and everybody, my staff, everybody took Covishield only because that is what is available at that time. Covaxin came a little later and they gave what government gives only we can take. Tamil Nadu government gave us this first. Then after some time they said we have only Covaxin. I said okay, we'll take that. Then they said no, now Covishield. I said okay, we'll take that. Whatever they gave, we were taking. So we have given both. Both have worked well. Then we did antibody tests to see when it's rising and all. We did it on ourselves, we did it on others. So we are measuring it like a research study. It goes up after about 4 weeks. First 2 weeks, nothing happens. Then we have been wondering, did we really get a vaccine or what? Did we get distilled water? But then by third week, fourth week, it started going up. And after the second dose we took, it jumped. The antibodies jumped up. So we know what they're saying is correct. Only after the second one, you really get, fully protected. So I think people should go ahead and take it and then wear a mask, because even after that you can get. I have seen many people after the second dose also, after 1 month also, get the infection, but they did not suffer from it, and they did not. It went off smoothly. And the rest of the family members who did not have the vaccination did poorly. They did well. So that is a proof. Ultimate proof is that the vaccine really protected you. Okay. Having said that, I know of one person who, after the second shot also, he developed severe COVID and he died also. Okay. So does it mean that, oh, then that case, one person died, therefore whole country, we stop the vaccination program? No. I know that that person also had other comorbidities. Something else went wrong. Biology is like that. Suddenly one stray thing will happen to the body. The body has its own mechanism. So never go by, I heard of this one case. Everybody hears of one case doing something. One swallow doesn't make a summer, as they say. So based on one case, never decide anything. Then you'll never decide anything. You'll hear of one Titanic sinking, so then no ships can go. You would have heard of one plane crashing, then no planes can run. Life doesn't go on that way. You have to find out why it sank and why it crashed, and try to learn from that, and life goes on.
Hopefully, I think now the way they found the vaccine, I think they'll find the reason for this virus to be severe or not severe, and where they go and stop.
It's not my research. It's what AstraZeneca has done. The studies in the UK. What they said was that the longer the gap you give, the better. So in fact, when the government first, you'll remember that the government talked about 4 weeks only for everyone, for Covaxin and things. I raised the flag right then, at least to my government. I couldn't go to central government, but to my government, because I was handling with the vaccines here and we were giving vaccines and so on. So I told my government here, saying that, why are you giving it at 4 weeks? It's supposed to be 8 weeks and 12 weeks. They said, well, this is the guidelines. We have national guidelines. Everything says 4 weeks. I said, sir, you're wrong. 4 weeks is not the one. It is 8 weeks. How can you give two separate timings for? I think you have to. I said, for science is science. You cannot say how do you do it and it'll happen. In India, so many things happen. So this also will happen. Then after about 3-4 weeks, they changed. They said, oh, now we can go from for 6 weeks to 8 weeks and so on. Actually, it is from 6 weeks to 12 weeks. The more you delay, the better is supposed to be, as far as Covishield is concerned. Covaxin, again, it's Indian data. We don't have any other country's data to go by. And therefore, the data is not that clear. I have not seen the antibody response after Covaxin in India and 1,000 people, 2,000 people. So I don't know. So I can't comment. But from what all the government has said and from what the company has said, 4 weeks seems to be fine. So be it. So 4 weeks Covaxin is anyway, it's a little weaker one. So better you give the second one fast as far as that is concerned. And therefore, I think 4 weeks is fine for Covaxin. For Covishield, not 4 weeks, at least minimum 6 weeks. You can go up to 12 weeks. So anywhere in that gap, if you're able to get, depending on the availability of the vaccine, you can take it. You were asking one more question about the vaccine. Something else you asked me.
I was asking you about why European countries are now not.
Oh, yeah. That's because they have, see, the AstraZeneca is made in UK, and it's a UK one. The UK trials have been done. They've been published in Lancet. There's a lot of data on it. Whereas here is a vaccine which is made in India, tested in India, not tested in other countries. They don't know much about it. So they have not, AstraZeneca Covishield is not an Indian vaccine. It's an imported one. It's there in the list of approved ones, along with Pfizer and Moderna and Johnson Johnson. Covishield also comes there. AstraZeneca comes there. So they have given that and saying, okay, any of these vaccines are okay. When you go with Covaxin and say, what is that? We haven't heard of it. Is your own vaccine? Where is the data? Where is the publication? Where is the thing? Now, today, I think the Indian government has, appealed to WHO and other places, saying that this is also a good vaccine, EU and all that, saying that please allow us, otherwise our people cannot travel with that. So I think the same thing for Chinese vaccine. The Sinovac which came was all published in China only. Mostly the data was dirty. So the other countries may take a little bit of time. But if we are transparent and we show all the results, I don't see why they won't accept it and say that it is also good enough. All we are saying is they show the antibody response. If they show that the efficacy is there and there are no side effects and people have taken it, I don't think it'll be a big deal for them to say that those who have taken Covaxin can also travel. I think it'll come. It's a question of time.
One very, very last question, Dr. Mohan. If you get COVID after the first vaccine and in between that and your second vaccine, what is the actual time period to wait before you take your second vaccine?
At least 2 to 3 months, because you've already had one shot, which has given you some immunity. Now you had COVID, which has given you a huge, it's like taking 3 vaccines or 4 vaccines that you've already taken. And once you've had this lot of inflammatory responses, going and poking once more, again, anecdotal, I know of one case where they had the COVID and went took the vaccine and the patient died. Now, again, one swallow doesn't make a summer. It may be totally unrelated. But to me, I thought, oh, that's a warning. Why be in a hurry? Because if COVID does not produce an antibody in you, an anti-vaccination is much lower than that, isn't it? So it's only like a booster. So I would suggest minimum 2 months you wait, if not 3 months, because anyway for Covishield they're saying 3 months even without that. Give it enough time, and then when this also makes sense because the antibody response after the COVID would have come, and then that must be declining. That's the time you go and give another booster, not when it's already boosted a lot. That time you go and give it, it may not even have any effect at all. So I think it makes good sense to, because you're not going to get COVID again in 8 weeks time, 6 weeks time. That has never been reported. Only after several months only, if at all, you get a second variant or something like that. So minimum 2 to 3 months you wait and then you take it. Sure.
Dr. Mohan, thank you so much for joining us today. Extremely enlightening session as usual, and many questions still unanswered. So we have to catch you back on that. Thank you so much for being with us today.
हेल्थ, फिटनेस और पोषण पर पाए बेस्ट डॉक्टर्स की राय सिर्फ famhealth.in पर, और हमारी YouTube पेज माय फैमहेल्थ पर सब्सक्राइब करना ना भूलें।